One thing we're definitely seeing is in terms of the safe and well-led categories, we quite often see they go hand in hand if people have had issues with CQC inspections. So it might be useful just to cover those two categories and see how maybe from care compliance, how you guys are preparing for those changes.
Yeah. So at the moment, especially on LinkedIn at the moment, there's a lot of care professionals that are sharing their knowledge and information, and there's a lot of resources out there. And one of those resources is a KLOE mapping document, where you can see with the new quality statements and the KLOEs how well they match up, if there's any differences with the new framework under each of the key questions. And in relation to SAFE, it's very similar, that all the topics do match. There's nothing that's a major surprise in SAFE. I think if providers are already collating the evidence within that category alongside, in line with the KLOEs, I don't think there's going to be any issues in what they need to evidence with the new framework. Same with well-led, very sort of simultaneous, goes across. Now with the new framework there is a sustainability, which is sort of new to the prompts, but they're not going to be assessing that for another year, because they do obviously notice that is a new area. So they've said even when the scoring updates get released in July 2024, they are giving care providers a whole year with regards to sustainability to be able to start to collate that evidence. So providers have been looking at sort of carbon reduction, waste, recycling, making sure that staff understand their impact on climate change, how people can look at reducing mileage in the local community, and how providers can respond to adverse weather conditions, so extreme heat, pollution reduction, things like that. So I would say that's the key difference with regards to well-led, from a quality compliance point of view, and what evidence is going to need to be collated.
Okay. Is that what you're seeing there?
Yes, so from a provider point of view, I agree with what you say, and everything. At the moment, everything is up in the air. We don't know. 21st of November is the day that the new assessment framework is going live, but CQC have stated that it's an ongoing process and it's going to be looked at. So managers, it's crucial that organisations and managers keep up to date. So one of the things I've found is that organisations haven't even been aware of what's going on, and they haven't even been on the CQC website to check what's going on. Now, in relation to SAFE, it's crucial that organisations aim to get this one in the bag, because if you don't get SAFE, then even if you get outstanding, which you might just get in another area, overall you'll require an improvement because you won't be safe. So it's crucial, as someone who looks at quality within our organisation, when I started in January, it was, let's get SAFE right. Even though we had it, it was like, let's really ensure that we've got SAFE in the bag, and then you can ensure you can work on the others as you go on, but SAFE is the crucial one. So some of the key things you need to make sure is when they come round is they'll check medication. So if you've got a medication and then in their health support plan it doesn't give any reference to any health condition, but this is for a certain condition, say for Parkinson's disease or dementia, or diabetes, then that should be in their support plan. And if it's not, then CQC are going, why isn't that there? So it needs to map through the others. But also your audit framework needs to look at, if someone has a medication error, then you need to be saying, okay, what was done for that? So in our organisation, if someone has a meds error, which people do have, it's a natural thing, is they're instantly taking off administering medication. And then there's a lesson learned. That's crucial. So first of all, you're doing an investigation. It might be that it was a systems error because we use a computer program to record our digital MARs, or we use a digital MAR sheet. So it might be that had not updated. So when we looked at it, it looked like there was an error, but then when you go back and investigate, oh no, it has, it's just updated. So then you can put them back on medication. If it was a human error, then you look at why, we put them on a medication course again, and then we do their observations again. The requirement is that you do 2 observations. We do 3 twice a year, unless they make a medication error. And if they make a medication error, then they go on medication training again, and they have to do a lessons learned, and they have to do observation. And then you sign it off. So CQC come and say, you had an error, what did you do? And any lessons learned come to our quality meeting. So we have a quality meeting every month that would come to a quality, which all managers attend, then that would be passed down. So you're actually showing good practice, or if there's anything you need to change, then it'll change. So that's what we're looking at, is ensuring that our systems are robust and communication is going through, so that people can understand.
Yeah, I think communication's key, that even if with the evidence categories you can show a beautiful suite of evidence, you've ticked every box, if the staff understanding's not there, or there's a culture where staff don't feel like they could put their hand up and say, I think I made an error, without reprisal, I think that's the culture part of it as well, and that's why CQC are saying that they don't want to get into a checkbox culture.
Yes.
Because if everybody's so focused on, we've got this document and this checklist and this audit and this training matrix, and everything's great from an evidence point of view, but there's a culture problem, and with staff understanding, or the service users are not, getting a good quality of life, but the documents all look great, but actually the experience from staff or the residents and service users is not good in any way. They're putting the people first. That's the key with the new framework. It's all about the feedback. That's why that's sort of so prominent under each of the key questions now as well, in the evidence categories. So yes, evidence is critical, but it's also the experience for staff and clients as well.
Yes, one of the things we did for that was, so when a CQC inspector comes, your staff go into that rabbit in the headlights.
Yeah.
So what we're developing at the moment is a booklet that goes into each of the properties, so that if a CQC inspector comes, and these are discussed in monthly team meetings with all the staff, is that if a CQC inspector comes and you're unsure of anything, just say to them, one moment, I'll go get our booklet for communication. And in there we'll tell them things like staffing levels. So one of the things what CQC are looking at the moment is they'll ask the staff, oh, how's your staffing level? Oh, we're always understaffed. We've never got enough. Well, that's the care sector, right? But that's the difference between having enough staff and unsafe staffing levels. But CQC often go away and go, oh, have they got a right staff amount? Is it because the staff are saying we never have enough? So on there, in this file, it's updated every month. It will tell them, this is how many staff are in your team. We're fully staffed, or we haven't. There's a vacancy out for one, but it's being covered by staff doing overtime, or the bank staff we've got. So they can clearly say to CQC, oh, that's this month, that's last month, that's that. And if then they ask them something on safeguarding, well, there'll be information in there just to help them about anything. I know the answer, but I'm just a bit shocked at the moment. You've asked me this question, now mine's gone blank. Be honest with them.
Yeah.
So this information there is to tell them, but there'll also be the notes there from the staff meetings, so that we can document that actually we are communicating this.
Yeah.
And the staff know where it is as well, because that's a crucial thing, because it's about the culture. One of the other things we do in relation to culture is we have main quality for managers, meetings monthly. We also have another one called the shadow quality, which is run by our individuals. And they sign everything off. So what we're doing, we set what we're going to look at agenda with one of the individuals who he co-chairs it with myself. So we've done easy read documents for our individuals in relation to who the staff are, the key staff, our audit procedure, the I statements, we statements. They're all there in easy read. They've signed them off. And not just the I and we statements we've got from CQC, we've got those now. We've also made our own. and they came up with them. So we can evidence that actually, yes, we're doing yours as well, CQC, but we're integrating our own, because our individuals, through co-production, we're doing that. And then also co-production is, we've got our main board of the directors. We've got a shadow board of staff we're implementing this January. So staff have got staff representatives who come and meet monthly and then quarterly with the board. And so everything is done through co-production, and that then deals with the culture.
It does.
Which deals with communication.
Yeah. And I think with feedback as well, obviously that's on each of the evidence categories, feedback is key. I think sometimes feedback can be perceived as things that have already happened or what have already been experienced. But also feedbacking does include input. So, into systems and processes, how can we make this better? It was actually a staff member that suggested this improvement, or, somebody who uses our services who requested this, and we've now implemented that. So that also comes under the feedback. It's not just past, it's also looking forward as well.
It's interesting with staff. I mean, do you find most staff, when CQC turn up, staff would be worried about what to say? And
they go blank. I mean, you do it yourself sometimes. When someone comes in, you're so they get frightened, or they get a bit want to say the right thing, or they don't know what to say, that document just helps them. And also we discuss it now in the team meetings which we've started, so they're monthly. In fact, they're not just team meetings, we do those through co-production. So our monthly staff meetings, which each team has their own, they're done in co-production as a team supervision as well. So the agenda, say 45% is set by the staff team, 45% is set by the team leader, the manager, and then 10% is coming from the organisation, which is across all teams. We'll discuss that. So it's now co-production, but you're also doing a team meeting, which is also a supervision.
Yeah.
So in its peer supervision, within the team, so that then you're doing more than the supervision CQC required, but it's a staff meeting. But you've set it up using a framework for a supervision, which is co-production. So you can communicate. So those booklets we create are updated every month through those meetings, and we pass down. So you've got that communication going up and down, and that's crucial. So staff know what to say. So you start talking to them about, if a CQC officer comes, this is the importance about the medication. This is the importance about what they'll say about safeguarding. And if you're unsure, just say, one moment, here's the booklet. Let me go through it. So they've got those prompts. We also give them little key rings with booklets on them so they can carry them with them as well. But staff being staff, they often forget them. So this booklet's there as well. So you're covering every option.
And if you're using your staff meetings as supervision, you've got documents from the back of that as well, which is your evidence towards the fact that you're well led.
Exactly.
And you can use that towards your CQC evidence, but also your training and your policies and your procedures and everything that goes into it.
So it's.
I think they're really good examples. I mean, certainly from my experience, a lot of the problems stem from failures in the safety and the well-led categories. Just on your comments then, Nathan, something sprang into my mind, and that was reading a recent report, an inspection report, and the member of staff that was spoken to couldn't remember where the policies were kept. Now that staff member clearly knows where they are, but was so nervous about being spoken to by with the inspector, they just froze, like you say, the rabbit in the headlights. I think that's a really good way of describing it. But that's the idea of the booklet. I think it's a very good one. I would just add as well, again, from the cases I deal with, and it ties in with Rachel's comments as well, that if it's right at the top, that feeds down through the staff, through the procedures, through the systems, and then you have a safe. Ultimately, the provider has to be safe. As you say, you can be great in every other area, but if you're not safe, you've got a fundamental problem. If your systems and your management team are on board, they're aware of what's coming, they're aware of how to deal with it, they're proactive, and they're keen to engage, then that should feed down. And it's the organisations that don't have that ethos, they don't have that mentality, that in my experience, they're the ones that will have the major problems, and they're incredibly, as you will know, they're incredibly difficult problems to fix. So if you can start at the top, that's a superb way of approaching.
Yes. In relation to the environmental one, I wouldn't leave it till later on. We've already started. So we did in our shadow quality of the individuals, we started looking at how we can be greener. And we got one of the training officers to come and do some 20-minute interactive for ours, because we deal with people with learning disability and autism, so they like interactive. And we brought household bottles in, what you'd be putting in the bin, and which one does they go into, and looking at them to show you, and then how can we implement this, how can we look at green things. And then we send one of our individuals to the local learning disability strategy meeting, which goes off in North Yorkshire, so they can go there and then bring that back, and then we can show them that they've got their documentation. Okay, how are we going to use all that? We take that to the shadow quality, and they go, well, actually, we want to use just this part. Okay, that's fine, because it's done in co-production. It doesn't mean that we might not, as an organisation, put other things in place, but that's what they want to do at this time. So you can show CQC that actually you're working towards something, even though, and that will show well-led anyway, even if they're not looking at that. It's been responsive and well-led already.
I think starting it now means you've got a whole year of being able to collate that data of, well, this is where we were and this is now we've taken sustainability into account, this is what improvements that we've made, and that's a whole year of data then that you've got to evidence.
I think a really good way of evidencing things that have been suggested by the staff team or suggested by service users or suggested by family members is to kind of have a visual display of that within the organisation, whether it's in the office or the corridor or the staff meeting room or the service user areas, like a kind of you said, we did type thing, so that you show that you've acted upon the suggestions and the feedback rather than it just kind of getting filed. And then you can obviously use that visual display to say, well, you know, you wanted X, Y, and Z doing, we've done this, this, and this, and kind of put it in a visual way so that service users who might not be able to understand, you know, written formats as such can actually see it in a visual way with photographs and colours, and you can actually take a picture of that and use it as part of your evidence to put onto your care management systems or into your software, whatever it might be, and to show to your inspectors. Obviously with the single assessment framework, the evidence is going to be reviewed on a kind of continual basis. It's not going to be focused just on a single point of contact where the inspector comes in and looks, so you do need that kind of way of being able to properly store and present your evidence of outstanding practice on a continual basis.
So I think that's a crucial point. The digital way everything's going digital is that by 2025 the healthcare sector is supposed to be digital, and a lot of organisations still haven't made that move to digital, which are going to struggle with this new framework because you've got to be able to share on a continuous basis that information.
It's an ongoing thing throughout the year.
So that move to looking at now for organisations who haven't made that jump is looking at, okay, what is good, what is a good software, and then moving towards that. And understanding that the software you have now might not be the same you have in 3 years' time, because things are evolving rapidly. So you might go, okay, we're having this piece of software, but in 3 years, if that hasn't changed or improved, we might have to change somewhere else. But that's the nature of the work now.
And be in line with the single assessment framework. Be aligned to that, otherwise it's outdated.
I think being open to change is key now. Obviously, this is happening regardless. Obviously everybody needs to adapt to that, but I think we often hear, you know, challenges that our clients face is when there's a culture of, oh, we've always done it this way, and it's, you know, if people have been there for a long time, managers have been there for a long time, so I think it's key to sort of get that change culture, you know, get everybody involved with this transition so that people are aware that, you know, we're moving, things are changing, and we all need to adapt and change with it.